Good morning. Our new class is drug abuse and de-addiction. In this topic, we will learn about a few drugs which have abuse liability and as well as few important points about the management of this drug abuse. Drug abuse means it's the persistent excessive use of the drug which is inconsistent with or unrelated to the medical or social practice. Actually, this abuse includes the use of mainly the illicit drugs, for example, cocaine, LSD, cannabis, etc. And the primary motivation or aim for the drug abuse is the anticipated feeling of pleasure, which is derived from the CNS effects of the drugs. Before moving on to the drugs having abuse liability, we will learn about a few important terms. First is dependence. Dependence means it's an altered physiological state which is produced by the repeated administration of the same drug, which necessitates the continued presence of the drug to maintain the physiological equilibrium. That means in order to maintain the physiological equilibrium, you need to supply the drug again and again after a prolonged use, and the discontinuation of the drug which will be result in a characteristic withdrawal symptoms or abstinence syndrome. And the next term is addiction. Addiction means compulsive drug using behavior in which the person uses the drug for personal satisfaction, often in the face of non-risk to health, and it is previously known as psychological dependence. And in persons with addiction, the withdrawal of drug does not usually lead to abstinence syndrome. Only the physical dependence usually produces the abstinence syndrome. Abstinence syndrome means which is a term used to describe all the signs and symptoms that occurs on withdrawal of a drug in a dependent person. The next term is tolerance, which means a decreased response to a drug necessitating larger doses to achieve the same effect. That means if you administer a drug at a particular amount for a long time, you won't get the desired response. So if you want to get the desired response, you should increase the dose. Next is the dopamine hypothesis of addiction. It's an important concept in the formation of dependence or addiction. Dopamine is the important culprit in the formation of dependence to any substance. Dopamine in the mesolimbic pathway play a primary role in the expression of reward. Most addictive drugs have actions that include the facilitation of the dopamine effects in CNS. Excessive dopaminergic stimulation leads to pathologic reinforcement such that behavior becomes compulsive and no longer under control, which is a common feature of addiction. That means whenever you take a substance causing addiction, there will be a feeling like reward. That means dopamine secretion is increased in the mesolimbic pathway. That means that behavior become constant. That is the basic concept in the formation of dependence or addiction. Before moving on to the drugs causing dependence, we shall see few important principles in the treatment of drug dependence, which includes psychotherapy and psychosocial interventions. So this psychological support, behavioral therapy, all those things are essential in the treatment part of a drug dependence, because this patient should maintain their motivation to quit this dependence, and substitution with a less addicting drug, gradual withdrawal, and abrupt withdrawal usually leads to withdrawal syndrome in case of physical dependence. So in order to avoid that symptoms, we should gradually withdraw the dependent agent. And prevention of further dependence. That means once he or she stops that intake, it's very essential to avoid the reintake, and educating the patient about the complications, immediate as well as long-term complications of the drug dependence. Now we are moving on to certain drugs which are mostly associated with this dependence, and first we shall see their overdose effect and withdrawal symptoms, and later we will discuss about the treatment of all these withdrawal symptoms. So the first group is amphetamine groups, which includes amphetamine, cocaine, And on overdose, it produces hypertension, tachycardia, agitation, hallucination, seizures, and may leads to death. And on withdrawal, it leads to irritability, increased sleep time, disorientation, depression. And these sedative hypnotic groups, barbiturates, benzodiazepines, ethanol, on on overdosage, it leads to slurred speech, dilated pupil, weak and rapid pulse, shallow respiration. This respiratory failure may leads to death. And on withdrawal leads to anxiety, insomnia, delirium, tremors, and seizure and death. And the third group is heroin as well as other strong opioid agents, which produces constricted pupils, clammy skin, nausea, respiratory depression, and coma in overdosage. And on withdrawal, it leads to lacrimation, rhinorrhea, hyperpnea, tremor, chills, and cramps. The first group is sedative hypnotics. Sedative hypnotics mainly includes barbiturates as well as benzodiazepines, but here we include ethanol also here along with this because it also has more or less similar action with this sedative hypnotics. And benzodiazepines are the commonly prescribed drug for anxiety, and they usually have a low abuse liability, but this short acting barbiturate, example is ecobarbital, have high addiction potential. Among the benzodiazepine, this flunitrazepam is known as a date rape drug. That means this drug was used to make the victim rapidly incapacitated and also has a amnestic property. And another drug which was used for the same purpose was gamma hydroxybutyrate. It's also render the victim incapable of resisting the rape. Then it's a treatment of sedative hypnotic overdose. So the most important thing is to maintain a patent airway. So for the respiratory support, most of the time the patient required to get a ventilatory support. And flumazenil is the specific antidote for benzodiazepine overdose. It reverses all the CNS depressant effect of the benzodiazepine, but there is no specific antidote for barbiturates. So in case of poisoning with this barbiturate, only respiratory support can be provided. Then it's the treatment of the withdrawal symptoms by the sedative hypnotic agents. The first and foremost thing in the treatment of the withdrawal symptom means there is substitution with a long acting agent. This long acting agent prevents the development of acute withdrawal symptoms, and so it should be followed by a gradual dose reduction. And sometimes this clonidine or propranolol also have a value in suppressing the sympathetic overactivity associated with the withdrawal of this sedative hypnotic. Now we have certain agents like opioid receptor antagonist naltrexone and NMDA receptor antagonist. NMDA receptor antagonist is the glutamate receptor antagonist, acamprosate. They are both useful in the treatment of alcoholism. And another term is known as therapeutic withdrawal. That means when this benzodiazepine group of drugs it's using for a long time. That means for some conditions like anxiety, we are using these drugs for a long time, and following that, if you stop the drug abruptly, there will be the therapeutic withdrawal symptoms. Next is opioids. So first thing is treatment of the opioid overdose. So we have certain specific antidotes for the opioids like naloxone, naltrexone, and nalmefene, and we can reverse almost all effects of this opioid overdosage by the specific antidote itself. But for the initial management, patient should be in a ventilator because these opioids have strong respiratory depressant action. Now the management of opioid withdrawal. Opioid withdrawal reactions are extremely unpleasant, and at times it leads to death of the patient itself. And the treatment of withdrawal includes replacement of the illicit drug with a pharmacologically equivalent drug with which having less dependent property, for example methadone, and followed by slow dose reduction. Buprenorphine, it's a longer acting opioid with partial agonistic activities at the opioid receptors. It can also be used as a substituting agent during the treatment of opioid dependence, because it initially suppresses the development of acute withdrawal reactions. uh, for the treatment of opioid withdrawal, we can't use specific opioid antidotes like naloxone, naltrexone, because they rapidly precipitate withdrawal reactions. The next group of drugs are stimulants, which mainly includes caffeine, nicotine, etc. Even though they have medical side effects, we people still using all these agents. So caffeine is mainly through the beverages and nicotine through the tobacco products. Cigarette smoking is one of the most common preventable cause of death. Its use is associated with high incidence of cardiovascular, respiratory, and neoplastic disease. Next, we have withdrawal symptoms of these stimulants. So, withdrawal of caffeine produces lethargy, headache, irritability, and the anxiety and the mental discomfort, which is experiences from the nicotine discontinuation. These are the major obstacles to quit the nicotine use. Then toxic features of these stimulants: acute toxicity, which usually result from overdosage of these stimulants, which leads to first this excessive stimulation of central nervous system, which is associated with tremor, insomnia, and nervousness, and cardiac stimulation leads to arrhythmias, and this nicotine overdosage sometimes leads to respiratory paralysis. Then it's smoking cessation. To avoid the withdrawal symptom, we have to initially replace the nicotine. This nicotine replacement could be in different forms like lozenges, gum, nasal spray, and transdermal patch. This nicotine gum or patch, they do not achieve peak levels as with cigarette, and they do not produce the same magnitude of subjective effect. All these methods, they are successful in suppressing the withdrawal symptoms of nicotine, and so the smokers are able to transfer their dependence to the alternative delivery systems, and thus they can gradually reduce the nicotine dose with minimal symptoms. But for the complete success, you have to use behavioral therapy along with the nicotine replacement. We have another agent which is an antidepressant, which is known as bupropion, which is said to be useful in improving the abstinence rates, and we commonly used a sustained release preparation of this bupropion. Next, we have varenicline. It's a partial agonist at the nicotinic type of acetylcholine receptors. It partially stimulates the nicotinic receptors, thereby reduces craving and prevents most of the withdrawal symptoms. Even though it improves the abstinence rate, it has certain adverse effects, like it increases the risk of developing suicidal ideations. The next group is amphetamines. Amphetamines act by inhibiting certain transporters in the central nervous system. These transporters, they reuptake certain neurotransmitters like dopamine, norepinephrine, serotonin into the preganglionic membrane, so to terminate their actions. So by terminating the actions of these transporters, amphetamine increases the concentration of these neurotransmitters. So thus they enhances their action. So they causes a feeling of euphoria and self-confidence that contributes to the rapid development of addiction or dependence. Drugs included in this class are dextroamphetamine and methamphetamine. Chronic high dose abuse leads to a psychotic state with delusions and paranoia, which is difficult to differentiate from schizophrenia. Overdosage of this amphetamine produces agitation, restlessness, hypothermia, tachycardia, hyperreflexia, and sometimes seizures. For the treatment of this overdose, we do not have any specific antidote. We have only supportive measures. Supportive measures are mainly directed towards the control of body temperature, prevention of the development of arrhythmias or seizures. So first part ends here. and we shall continue the remaining in the second part.